Still, we are not odd. Hear you.
Dr. Ajit, can you just go to the audio settings and connect your audio, please? We see you, you are unmuted, but we are not able to hear you at all. Yes, we can hear you. Very good morning, Dr. Ajit.
Good morning. Just I would like to say we can wait for a while because we have only 45 participants, or we can start now. So, okay. So we can start now. Good morning to all the participants, and especially to our chief guest today, Mrs. Gitanjali Jha Chakravarti, Regional Director, South Asia. First of all, from the CRC, like Composed Regional Center for Persons with Disabilities and the Motivation India, we together we have organizing this webinar, 24-hour posture care management for the person with disabilities. And as we all know, posture management is very, very important for everyone, every individual. When we talk about the person with disabilities, its importance increase many folds. So for the today webinar, certainly we will be learn to how to make the posture management for our special child or person with disabilities. And this webinar, we have a resource person. It's a very highly qualified resource person like Sudhakar Govind Sara, Siddharth Gaur, Praveen Kumar, Sachin Kondu. In the next 2 hours, we will hear to these experts, and the moreover in the leadership of our chief guest, Gitanjali Jha Chakravarti. And as I aware, I met to the madam. A madam has a very vast experience of the 25 years in the different capacity with the Apnale, Childline, Arman, and with the various capacities. It means madam has a experience of the ground level to the now is the management level, top level, and now as a holding a regional director post in the Motivation India. So certainly, madam word will be guide us and certainly motivate us for the doing such kind of the things. And really, I am very appreciating Siddharth and our own staff, Sachin, for the collaborating and doing putting and making this webinar for the today. And certainly, this kind of the activities with the CRCs and Motivation India will make benefit for the both of us, CRC and the Motivation India. And certainly, we will look forward for the more such kind of the activities in future also. And certainly, from the Gitanjali madam, I'd like to the more collaboration and the more cooperation from the your side. So from this, I again thanks to the Gitanjali madam and whole Motivation India family and all the participants for joining us. Thank you.
Thank you, Ajit ji, for such wonderful and kind words. I must say in this room, while I have experience of 25 years, I think in this topic, I'm the least knowledgeable person in this room today. So, but hello everyone. It is with great pleasure that I welcome you all to this workshop for 24-hour posture care management for persons with disabilities. The request was coming from various corners of the country to our team to conduct such a workshop. And Motivation team took the onus of organizing with great gusto along with the support of CRC Ahmedabad. So I'm happy to see participation. We have more than 120 people who have registered, and I'm sure they will be joining soon. So I'm happy to see participation in such large numbers. I think 60 people are already online. So today's session is very important for 2 reasons. So of course, all the things Ajit talked about, that holds. But there are 2 important things which have happened in recent past. One is happening, one is going to happen. So WHO has just released the new guidelines for wheelchair service provision. The guidelines emphasize that the best outcomes in wheelchair access occur when wheelchair users have the benefit of an individual process of assessment, fitting, training, and follow-up provided by trained personnel. This is something we at Motivation are fully committed to and are also advocating for all the time. Secondly, on the 11th of July, there is launch of World Rehabilitation Alliance. This will be streamed online also, so I would request everybody in this room to please check it out. So as you know, the Rehabilitation 2030 initiative, it draws attention to the unmet need for rehabilitation worldwide. And it highlights the importance of strengthening health system to provide rehabilitation. So in this room, we have all the rehabilitation professionals. We know that no matter how much work we do, we cannot meet all the requirement. And this recognition is there worldwide. And the whole idea of strengthening health system, making rehabilitation as a part of health system itself will make a world of difference. So of course, I know that you will learn many new things today in the workshop and you will be able to clarify your doubts. And I must say, I'm very thankful that Ajit ji is here today. I was lucky enough to meet him recently in Ahmedabad, and I was totally bowled over by his commitment to providing quality care to people with disability. The new facility is world class. It's amazing. The systems, the processes, and the vision of what Ajit ji has for that CRC is anywhere at par with the world. And that is their vision also, if I remember correctly. So thank you, Ajit ji, for your continuous support. And yes, I totally agree with you. We do hope to hold more such workshops as and when requirement comes. But as we discussed when we met, that we do plan to hold at least 3-4 of these workshops in a year. So thanks again for your support. And so without taking any more time, I wish all the participants and Motivation India team the very best and enjoy your workshop today. Thank you.
Thank you, madam.
Thank you, Gitanjali, for the quick sector update. So can I request Praveen to share the screen, please? So good morning, everyone. I'm Rajlakshmi Das. I'm the head of fundraising and communications for Motivation India. So I will be quickly introducing all our resource persons who are extremely experienced in the sector. They're all rehab professionals, and they have been working for more than a decade in this sector. So we have with us Mr. Sudhakar Govindswamy, who is a development professional and a physiotherapist who has done his master's in rehabilitation science. He has over 15 years of experience, and with Motivation India, he works as the regional manager of South Asia for training and program quality. So Mr. Sudhakar is also certified by the ISWP USA for his rehab trainings, and he's also a member of Indian Association of Physiotherapy, Indian Association of Cerebral Palsy, and RESNA North America, ISWP Integration Subcommittee USA, and PMG Group UK, DDO Canada, clinical and technical. He's also the clinical and technical specialist team of Motivation Charitable Trust UK. So next we have in our as the resource person, Mr. Praveen Kumar Reddy. He's also a development professional as well as a physiotherapist by profession, and he has over 14 years of experience. And with Motivation India, he works as the head of business development and partnerships. And Praveen is also very, very highly qualified and a certified trainer of ISWP, and he's also a member of Indian Association of Physiotherapy. He's a member of Postural Mobility Group UK, as well as ISWP Integration Subcommittee USA. He also has a membership with Diversibility Disability Organization Canada. He's also one clinical and technical specialist in the Motivation Charitable Trust UK. So then we, the third resource person with us, we have Mr. Siddharth Gaur from Motivation India again. So he's also very, very highly qualified and experienced physiotherapist. He has over 12 years of experience in the sector, and he works as the assistant manager trainings and clinical support at Motivation India. Not to miss out that he is a WHO certified clinician. That at Motivation we always encourage things to be aligned to the WHO guidelines. So he is one of the certified clinicians from the World Health Organization, and he is also a consultant for rehabilitation and assistive technology. Plus, when we talk about his experience and his memberships, he is one of the members of the Indian Association of Physiotherapists, plus Postural and Mobility Group UK, clinical and technical specialist team of Motivation Charitable Trust UK. So I really welcome all of you to this session, and I really look forward to learning quite a bit about the 24 hours postural support from our experienced resource persons. So let's begin.
Thank you, Rajalakshmi, for the beautiful introduction. So Sudhakar here from Bangalore. So welcome you all. A little excited to see the huge crowd in this place, and we have a diverse audiences from the different professional group, professional background, we can say, like from the physiotherapists, occupational therapists, special educators, prosthetists and orthotists, some of the managers and directors. Everybody is like we have a diverse group, that's what I can say. And the experience range from 2 years to 20 years, more than 20 years of the audiences are there in this particular group, and it is glad to have this particular presentation and this particular topic to be discussed here. And quickly, can we just can I have a presentation from Praveen? Can you share the presentation?
Sure.
Hope I'm audible to everybody. Praveen, am I audible?
Yes,
Yes.
Sudhakar.
Okay.
Loud and clear, loud and
Very
clear.
nice, very nice, very nice. Thank you. And the posture care management is huge. It's a huge topic. The 2 hours is not sufficient to discuss this huge topic. It takes like maybe weeks to months to discuss and have hands-on practice and all those things. What we thought is like, it is like one of the first initiative with this wider group, we thought to have this webinar, but we have the experience of conducting these webinars from 2020 onwards on this posture care management across countries, not only in India, even Bangladesh, Nepal and other countries also we have conducted. So, but in this particular webinar, we'll try to have a little shorter version of the posture care management, about the basic concepts, what happens the biomechanically or physiologically, and what are the different supports required, that we'll be just seeing. And in case any questions, if you all have any queries, we have a separate session towards the end of the session, so that you can drop your questions in the chat box or else a Q&A section, so that we can address at the end of the session. That's what I can say. And after the 3 presenters, we can have the Q&A session separately. This is one information for everybody. And for the convenience of the wider webinar, we have we have muted everybody. So if any questions, please feel free to put it in the chat box. So can I have the first slide, Praveen? So the overall objective in this particular 3-part webinar, we have first topic is I'll be presenting about the 24-hour posture care management, and next followed by Siddharth will be just talking about what all the postural distortions is going to happen, what all the postural deformities are you can see in the from the trunk, from the legs, from the body, that we are going to see, and then how that impacts for the different biomechanical changes and physiological changes in the body, that we are going to see. Followed by Praveen is going to discuss about the different supports at the sitting, at the lying, at the standing. What are the different things we need to consider? Because many of us are working professionals and some of us are students. You would have seen the different supports required for the children as well as adult, but what exactly, that we are going to see at the end of the last session. The next slide, Praveen. So before going to the posture care management, I would like to present this picture for you all. Like always my favorite, I can say. Both the pictures, if on the right hand side, he's also sleeping, but you see the difference. Both the postures are something different, but the purpose is also different. We can see the comfort, we can see the support surfaces, and all those things are totally different. So it's not just a posture we need to observe. It is like overall the function of a person, what the person wanted to do it in a comfortable way. That's what we are going to see overall today's session, along with how it interlinks with the different postural deviations or different postural needs for the person with disabilities. Can we go to the next slide, Praveen? So what is posture? That's everybody have this definition we talk about, right? So in a simpler way, the posture is the way how the body parts are arranged and related to the different joints or different parts, maybe upper limb to lower limb, or upper limb to pelvis, or pelvis to lower limb. So this is how we are going to just discuss, and the way in lying, in sitting, in standing, how it interlinks and how it affects, that we are going to discuss. So that's what the overall about the posture. Next slide. Then what is posture care management? If you see, it's a kind of approach, rehabilitation approach, we can say, to protect, restore the body shape or muscle tone to improve the quality of life. That's the overall approach for all the three different basic postures of the person or a child. So the approach, just click the next button for me. Yes, so the approach should be gentle, respectful, consistent, and it should be effective enough for the person, because here it means many times we as a rehabilitation professional, we would have given some sort of support for the children or an adult. What happens, that is not providing consistently, that is not provided gently. We would have seen many children are like strapped too much here, or the children are hanging in the chairs, and the children are just sliding down from the chairs or wherever the support is provided, and it is not gentle usually. So this posture care management, always it should be gentle, respectful, consistent, and effective for the children or a person over a course of time. So that's what the posture care management is supposed to be. Next slide, please. Yeah, and when we talk about the posture care management, many audiences now we are having here, but it is not a new idea here. It is like started from way back in 1970s and 60s only, where the Fulford and Braun, they started discussing about the posture management for the children with multiple disabilities and severe disabilities. From there it is started, and slowly we can say every decade there is some or the other growth was there. Afterwards, like in 1980s, there are the scales came in, like to assess the sitting ability. And then afterwards there are some indices, the postural care indices was developed in 2010, and then recently in the western world, western part of the countries, 2016 and 2023, there are scoping studies came in to understand what is the evidences are available on this particular posture care management. That's what we can see. But there is a huge growth is happening in this particular area, and on the other hand, this growth is like very least considered, or it's very less considered in the developing countries like India, Bangladesh, Nepal, and this part of the world, in African countries as well. So this is very much concentrated area. This has an impact on the long-term disabilities or long-term conditions. Can I have the next slide, Praveen? Who needs posture care? So now I'm talking so much of evidence. Now when you see who needs the posture care, if you see anybody who has a limited movement, who are unable to change their positions on their own, and are varieties of position by means like if the person is lying down for quite a time, whether the person can sit, whether the person can alter the movement from the lying to sitting, or when the person is sitting for quite long, if the person is able to stand, move around, even in the standing itself, they can change the position, lying itself, they can change the position or not, that we need to see. If that is limited, then definitely this is the place where the person required a posture care management. And there are some common conditions, we can say children with developmental disabilities, severe and complex neurological disability, people, adult maybe, or the elderly people also who need posture care, who cannot able to change their position. And if you see, can you just press the next button, Praveen? If we don't help these people, definitely it can go horribly wrong. That means like they developed fixed problems, they developed systematic problems, they develop a physiological issues, and that lead to sometimes there are some studies says that can lead to death also. That's what the overall the importance we can say. Again, it is not immediate, it's a slow poisoning, how we say, the slowly the postural deformities develops, and that affects the systematic things in the body, and then that leads to a non-functioning or less functioning, and finally that leads to end of the life of the person. So that's how the posture care is so much important. And can we see the common conditions from the next slide? There are some conditions like cerebral palsy children, and when they move from the childhood to the adulthood, again still it is furthermore posture care management is important. And the person with spinal cord injury, especially at the higher level, who has like less trunk control, less upper limb movements, even with the paraplegics also, there are like many postural deviations occurs. So how are we addressing in a different positions? Then brain injury, head injuries, scoliosis, spinal muscular atrophy. These are the different conditions you might be aware about it. And the other conditions you see like osteogenesis imperfecta. So this is one of the congenital condition where the multiple contractures and multiple deformities happens from the childhood itself, where the child difficult to lie down, where the child difficult to sit down. I have seen a child in 2013 sometime. The child, the bony prominences, the spine prominences are so much, the child is having so much of pain, the hip cannot be opened. The sit, like how we sit in a chair, the same way only the child will be lying down. Then imagine how much the child will undergo. So how the postural management helped the child was like, it's excellent. The mother was explaining very well. She was like really getting a help for the child as well as for the mothers, because over a course of time, the child is getting bad postural issues. Because of that, handling was difficult. A next condition we can say dementia. It's a like mental health condition, but still it affects the physical mobility, it affects the sensations and all those things. Because of that, the older people goes into the like fetal positions. Again, there also there is a huge need for the posture care management in lying as well as the sitting. And there are some other syndromes. These are all syndromes again related to the developmental disabilities, Reed syndrome, Ehlers-Danlos syndrome, or Angelman syndrome. So these are the different syndromes at the different level of the brains and different level of the developmental problems. It leads to movement issues as well as the postural issues. So ultimately what happens, many of you would have seen, every time when you see a child at home, the child will be lying down on the floor without any supports, without any additional things. And they may come for a therapy for some time, and again once they go back, the child will be in the same position. This is what happens many times for the children, and even nowadays it happens similar things for the elderly people also. They most of the time lying down. So what happens is, whatever the posture adopted in the lying, that directly affects in the sitting and standing. So that's how it's directly linked with the posture care management. Can I have the next slide, please? And what happens when a posture care management, you're talking these conditions we're talking, and what happens when many children or many young people, when they have the disability, kind of cerebral palsy, or even you can say the young adults having the high level of spinal cord injury, initially their body parts are really good. You might be knowing, like seeing their body parts are flexible, the hip is flexible, knee is flexible, they may be showing the tones, but still it is flexible, right? But if because of the consistent improper posture, because of the tone, because of the sensory impairment, body accommodates that particular posture. The second point, if you see, and from there what happens is the person or children, they are not managed well, their habit and things, no, it keeps them have a skeletal changes. Here the skeletal changes is like the bone weakening or the atrophies we are not talking about. It is more into the joint contracture, muscle shortenings. These are all what happens, like leading to the reduced postural choices. When the person is sitting or lying, they may not be able to lie comfortably. They may not be able to do the full range of sitting or full range of lying. They may not be able to changing the position. That's why it is happening. It's again directly linked with the gravity, because as soon as you have some tonal changes, a small deformities or small angle changes in the joints, directly the gravity will influence from the above and below. So that what happens is, over a course of time, again the person will have a flexible deformities to the fixed deformities. That's how the overall the posture care management, the concept comes here. So if the beginning, the level 1 only, if you are not managed well, if you are not address the proper postural care, definitely that leads to the secondary problems, and that is a permanent again. So that's what it happens in many situations. Can I have the next slide? Yes, this is what it happens, like a human sandwich, you know, right? top there is something layer, and then down something layer, middle it's like our body or our posture, whatever we can say. In all the positions you can see in the picture, the gravity from the top and the support surface where the person is lying down or sitting down or standing down. Maybe many times like in the name of comfort, many children are adult, they have given a good comfort sofa, good comfort bed. What happens? They sink in. Again, the support surface is not so good and the gravity acts, then they get deformed positions. Similarly, in the chairs also or sofas also, if the support surface is not supporting well, and definitely that lead to a gravity and support surface counteract, lead to body become a sandwich, and then it goes wherever the body parts moves around, and that gives a terrible deformities. Can I have the next one, please? Next slide. And maintaining the posture between the support surface and against the gravity is always a constant struggle. That's what it happens for the children as well as the adult. Many times you would have seen, you make the child sit in a chair, special chair or a wooden chair, and then we ask the child, hey, hold. That's what as a therapist or a special educator or any other, I'm not talking about the particular professional, but as an intervention we start doing. But actually what happens is, there the support surface is not so good, the gravity is acting on, the child really struggles to get the functional activities. Even taking a cup of coffee or taking a cup of a tea or just holding something in the front, that's become a huge struggle for the child, because the child is supposed to maintain the pelvis, hips, knees, head, all the body parts, then coordinatedly moving and catching the materials or the doing the functional activities. There it's a big challenging for the children as well as the adult. So that's where the constant struggle we can say. Can I have the next slide? Yes, the interlinks. So here we talk about lying, sitting, standing. Do you think everything is separate? Definitely not. In the posture, you can see, in the picture, you can see, there is a picture. Praveen, can you just stop the screen for a while? This is a windswept deformity, we can see. Everybody can see my slide, right? Sorry, my screen, right? Can you see the picture? Just a minute.
Sudhakar, maybe try removing your background.
Yes, I removed now.
Yeah.
Can you see now? Is it visible now?
Go ahead.
Absolutely, yes.
Yes. So what happens is, you have seen this is the normal sitting posture where both the legs are straight. This is normal sitting, you and me, like we are sitting like this, sideways or the front ways. Whereas in the picture, what you have seen, the legs are moved towards one side, right? Can you see? It's not straight. It's like deviated towards my left. But when you just make the same way in the lying, again, it is happening the same. Both the legs are falling towards the left side. This is what we say about the interlinks. When the person is not supported well in the lying, below the legs or between the legs and the trunk and the head, if this is not supported, the same thing reflects in the sitting. And the same thing reflects in the standing. You can see here, the knee is flexed here. Knee is completely, like we can see this thread. It is like, you imagine this is a muscle. And here the hip flexor muscles, it is resembled as a pink color thread, right? So these are like a fixed conditions. When you just in the lying position, if it is stuck, definitely if you make the person stand also, the person cannot stand. This is the position. You can see here, it is completely stuck at the hip fixed flexion position and knee flexed position, and it is hard for the person or the child to stand. So this is what the interlinks we talk about. Praveen, can you just reshare the screen? So if anything, if you see in lying, in sitting, in standing, any deformities or any deviations, if you see, it should not be corrected in only one position. It should be across all the three basic positions. If you are correcting, if you're giving a special chair or if you're giving a wheelchair for a person or a child, what's happening in the lying? We need to check about. What's happening when they stand? You need to check about. If these things are not there, and definitely that lead to a incomplete work what we are doing it. Right? Can you go to the next slide? And there is a huge debate, we can say, or huge discussions, we say, we are doing stretching, right? So after stretching, what is happening? Maybe we do like as a therapist or a special educator or any other professionals, the passive stretchings we do, right? So it's usually it takes some time from the day, and then there are some less evidences only it is available for the stretching. After stretching, what happens? If you see, it's a big debate and big thing. But if you see the positioning, it has a huge effect. Even the evidences. Can you just click the next one, Praveen? The positioning evidence, if you see, even in 1988, way back only, there are so much robust evidence came in. It is very active. After the stretching, you just take the child, put the child in a proper sitting device, put the child in a proper lying device, or put the child in a proper standing device. Not anything. Here it will not work. Like something is better than nothing will not work here. It is like you should say right thing for the people. That's how it works. So the positioning, it should be incorporated into the day-to-day activities. If the person is sleeping or if the person is taking rest, can we just set a sleeping system for the child so that the child can take a good rest after the stretching or after the activity? Again, whatever the intervention is provided, it is actively maintained throughout the day. So that's how the combination which works. It will not work alone with the stretching. That's what I would like to say here. Can I go to the next slide? And mostly we all heard about this international classification of functioning, disability and health, right? So in this, again, there is an evidence-based thing is saying about whatever the special chairs or the different supports, whatever we are providing, it will help the body parts. But again, as per the ICF, it should be focusing on activity and participation, right? So the evidence is saying because of providing these systems, different systems in lying, different systems in sitting, and different systems in standing, helps to do all the activities of upper limb function, mobility, it could be communication, it could be, or just coming out of home. By a good wheelchair, that itself a good mobility, right? That's including into the community. It improves the social skills, it improves the activities of daily living skills, right? So overall, what happens, the supports or the posture care management, it is though it is supporting the body part, but it directly impacts on the activity and participation of the particular person, right? Can I go to the next slide? And most of you are aware about this gross motor functional classification system. This is the classification system used for classifying the children with cerebral palsy. Cerebral palsy is one of the childhood condition, right? So this classification divides the children into the 5 different levels. As the level grows from the 1 to 5, the children are having so much of difficulty, so much of deformity, so much of dependent. That's how you can see here in the picture only. The level 1, the children are more moving. The level 2, children are more moving, a little lesser than level 1. And level 3, if you see, the children are more dependent on some of the mobility devices. Do you all think which level in this 3 required a postural support? If you see, many people may say level 3, but can you go to the next slide, Praveen? In the 4 and 5, furthermore required the assistive devices or the postural care management, right? But there is a evidence saying, go to the next slide, Praveen. There is evidence saying, yes, of course, GMFCS level 4 and 5 required a comprehensive postural management, but equally level 1, 2, 3 also, there are some hip subluxation, hip dislocations, hip migrating is happening. That's what the evidence says. And then it is very recent evidence. What I can say, it is not like very old evidence what I'm talking about. It's a 2015 evidence. So this evidence itself, it says even the level 1, 2, 3 also required a comprehensive postural care management. So any person or any child, if you feel they are not moving properly, they are staying in the same position, definitely they need to have a comprehensive posture care management. That's what I would like to emphasize here to everybody. And it is not just the people with severe disabilities only, even some of the mild conditions also we need to address, we need to observe, and we need to give a right solutions. Can we go to the next slide? Yes. So what it is, the incorporating the regime in a 24-hour, like lying, sitting, as well as standing. There is an example, like over a course of 3 to 4 years of the intervention for a guy called Tommy. We're going to watch a video now, how his postural deviations in lying and the supports lying and sitting is transformed his life. That's what we are going to see. Just watch the video carefully. We will share this resource also to you all just to rewatch again after the webinar also. Just carefully watch the video. Look at his neck and pelvis, hip level. At the end of the video, we can see how he is transformed. So this is the lying position for this guy before the management, the white shirt. Many times we hear the children are crying, right? So this is what it happens with the many people. Bass is the physiotherapist who helped to do the posture care in UK. He developed this video. Can you see the neck now for this boy in the wheelchair? Earlier how it was, and now see the lying how it is. This is how it is improved over a course of time from here to here. You can see the difference. So in the definition, I mentioned the consistent, the gentle. This is how it looks. So if you just do consistent, definitely you can see the huge change that improves the quality of life of the people. So to do this, the extensive assessment is done, proper measurement is taken, how much the supposed to be given, where supposed to be given, how much surface area. These all have a detailed assessment separately for lying, separately for sitting, and separately for standing. And each supports have a different assessment formats, and then that has to be like a hands-on practice has to be done. Then only it gives over a course of improvement. Not just like that, inserting anything into the body parts for the children or the adult. Thanks, Praveen. You can change. So can you see like how it is bringing a big change for a person's life? A person, somebody sitting like completely the neck bent, and the person is sitting like this. You imagine communication, eye contact. You imagine how the person is eating. You see how the person is more comfortable from the neck, how the balance it is. So this all makes a small thing, but it makes a big difference. Again, it was consistently 2 to 3 years or 4 years, they were just giving the intervention, and then continuous follow-up was given, not a just one-time intervention. Not one-time intervention was not helpful for anybody. It's a continuous process. Every 3 to 6 months once follow-up. After the follow-up, there is a revision, a re-edition, or re-supports were provided, and then slowly some support were added, some support were removed. So this is how the overall things will work. And how to identify the posture care, who needs the posture care? There is a checklist, simple checklist, Mansfield's checklist, we call it as, okay, and it has only 5 questions. Read the 5 questions. If you find if somebody is in the same position, somebody's legs are like inward or outward, somebody head is not so good, and somebody body is bent forward, and somebody body is not straight, symmetrical, we say, right? Symmetrical means like both the side equal. When I sit, my both the shoulders are the same level. If one is down and higher, then I may need the postural support, or I may need the posture care management. That's how this checklist, simple checklist, this will help you to identify any of your beneficiaries, wheelchair users, or the people with disabilities whom we are working to identify whether the person is required the posture care management or not. So this checklist, again, evidence-based checklist, it's free to use. You all can adopt in your settings so that you can understand who required. Again, after understanding, next slide, Praveen, you need to set a realistic goal. If they are in that position, what is your goal? Whether you want to prevent the postural deformities for a long term, or you want to just improve the comfort and reduce the pain. For example, that guy, Tommy, he was telling like he used to moan. He used to just call the people by moaning, right? Because he is not comfortable. So you want to improve the comfort and reduce the pain. That's your motto. Or you want to just facilitate communication, cognition, or functional skill, like that. You can set a realistic goal for each person after understanding or after the detailed assessment towards improving the breathing, digestion, towards improving the good sleep and preventing all the secondary problems. So that's how the whole postural management concept works actually. At the end, next slide, Praveen. So what the key message I would like to say is, the early identification in intervention is important. So we know early intervention in many places, many people are doing in a different perspective. But in the posture care management, how early you are seeing the person, how early you are intervening for the postural care management, you can prevent, you can protect or support, or you correct also some of the body postures from like extreme deformities. Also, getting familiar with the solution is one thing, but my motto, I'm not saying you give a special chair, you give a wheelchair, you give a standing frame. Equipment is not the end goal. The end goal is every child is unique and every person is unique. There is no definite solution. Work with the families, work with the wheelchair users, or work with the children with the disabilities or adults with the disabilities to find a right support or right kind of interventions to help them symmetrical body part, to be comfortable and to have a good quality of life. That's what I want to give a key message. From here, I'll just hand over to Siddharth. What are the some of the biomechanical changes, how it is happening, and we say in lying, how, sir, what happens, like how this deviations are happening. So Siddharth is going to explain very nicely with the different lying position deformities, sitting position deformities, as well as standing things he is going to talk about. So I'll just hand over to Siddharth. Any questions, please drop in the chat box. Let's address at the end. Thank you everyone.
Thank you, Sudhakar, for covering the concepts of posture care management. And without wasting time, I will start on the various deformities which are in the life. So, Praveen, can you make it a full screen? Yeah, thank you. So, we'll start with the different type of posture. Without getting to know this posture, we may find some difficulties to understand the various problems which are happening in the different postures. So there are 3 types of posture, which is called fixed posture, flexible to partway neutral, and the flexible to neutral. So Praveen, can you go on the next slide? Yeah. So in the fixed posture, what is happening there is the bony involvement. The joints have become fixed, and to support them, we need to accommodate, because we cannot make them in the neutral position. So we have to accommodate the fixed postures to make to avoid further complications. And in the flexible to neutral posture, so with some forces, the joint may achieve some range. Rest part is the fix. So for that, we have to provide support to maintain a neutral sitting posture for the person so that he can sit and maintain the close to neutral setting, neutral posture. In the flexible pathway to neutral posture, it is almost the neutral posture, but there are some limitations, but the joint involvement is not there. So with some force, we can achieve the normal position, and we have to provide the support to make the neutral position, as well as the it is comfortable for the person also. Praveen, can you go on the next slide? Yeah. So the common problem that we are seeing, you all have seen majority, lower legs. If you start with the lower legs, so the knee flexion deformity is very common in the children with cerebral palsy, or the other persons who are having the disabilities. Abduction is there, adducted legs are there. In the hips, like in the last presentation, we have seen the windswept deformity, subluxation would be there, and the majority, the chest wall shape distortion is also happening. This is which is we are not focusing on that most of the time, but it is also happening because of that the internal organs getting affected, and people are facing so many problems, like physiological problems are happening, pain, digestion, and the difficulty in the breathing also happen. And all these problems is creating also the communication. The child or the person is unable to communicate with the person because he's not sitting upright. So he is facing these things. Yeah. Next slide, please. Yeah. So if you can see in the normal chest, so in the standing position, the chest looks like the colored picture you can see. But I will talk in the supine position. Basically, the chest look like a hollow space where the all internal lungs and the heart set up. But the sternum and the spine are in the midline, and with the gap is both the sides is equal. But if the distortion is happening, so we will see in the next slide. So you can see the child is lying in the supine position with legs apart, and one leg is flexed and one is extended. So what is happening here? The gravity is pulling over the chest and the midline, on the sternum and the spine. So because of that, the chest is going one side where the gap is increasing. You can see the red line. One side gap is increasing, another side the gap is decreasing because of the rotational forces. So it creates the pressure over our internal organs. Yeah, Praveen, go on the next slide. And similarly, in the chest distortion is happening in the side line, where this is big. Majority when the child or the person is lying in the same side majority of the time, and one side you can see the chest is becoming flat and another side is the rounded. But as a consequence, the one side which is the down where the contact surface is more to the ground or the bed, so the chest is becoming collapsing in the one side, another side it is increasing. So again, it is creating the problem over the lungs and the chest. So these are the common problems happening with the children with cerebral palsy, or the persons who are having the spinal cord injury, muscular dystrophy. This is very common. We have seen in these kind of people. Yeah. Next slide, please. Yeah. And similarly, in the prone line, the chest distortion is happening, but because of the problem, the person is not able to lie properly in the prone line, and because of that, this trunk angle, hip, thigh, and the trunk angulation is getting reduced day by day. In the second picture, you can see the child, because of the unstable surface, or because of the instability, high muscle tone, the ribcage and the hips are getting collapsed. So further time, the person have problems, and he is not able to breathe. He is not able to, he or she will not able to digest. So this is the common problem which is happening with the chest distortion. Yeah, Praveen, go on the next slide. So yes, this is one question, and you all can type your answers in the chat box. There is a one picture of 4-year child, another is a 26-year child. So you have to just tell me which is the neutral sitting posture. I'll just wait for the 10 seconds. You all can just type your answers. Raj, can you just see the answers?
Yes, I'm waiting for people to reply on the chat box.
Okay.
Both are in neutral posture. Pamida says both are okay. Lovely. So can we have some more answers, please?
26
Kamal
years.
says the 26 years old person is in the neutral position.
There is no right or wrong answer. You can just feel free. to
Yeah,
talk on this
absolutely. There is no
session.
test.
It's
I'm
not a
going to
test.
give myself a prize if somebody wins. Yeah. So let us all participate in the questionnaire. Okay, so we have answers from two people. One is Famida and the second person is Kamal. So Famida says both are sitting in a neutral posture. Kamal says the 26 years old person is in the neutral posture.
Yeah, so the right answer, like both the answers are correct. There is nothing wrong or right. But if you see, like for a 4-year child, the child is not having the normal curvature till the age of 5 years. So for this is 4-year child posture is also correct. And in a 26-year-old, there are the curvatures like pelvis is there, and then the following the normal curvature like lordosis, kyphosis, and the cervical curvature is there. So both the postures are the correct. We will see some deviations in the next slides, like how it is impacting. Yeah, Praveen, can you go on the next slide? So in this picture, you can see the pelvis is tilted forward, and because of that, so what is happening in the trunk, the lordosis convexity is increasing at the lower back portion, and in the upper back, almost the trunk is flattened. So in the end, this is called anterior pelvic tilt. Because of the pelvic is tilted forward, the changes are happening in the spine, which is basically at the lordotic level. So this is directly linked. If the pelvis is changing, though, so our changes will happen in the upper body and also in the lower trunk. So in the lower body. So if you can see the uh, pelvis and hip angulation is reduced, and the knee angulation is getting more. So this will happen in the anterior pelvic tilt. Can we go on the next slide? Yeah. So in this, you can see the pelvis is rotating on the one side, like one side from my right side, the pelvis is going forward and the left side is going backward. So this is called rotation, and the rotation also affects the spine. You can see the up in this picture, the spine is also getting rotated. So this will again happen because of the high muscle tone in cerebral palsy, and you have seen like it is common in polio. Like polio is not it's almost eradicated, but in the polio it is more common, and the CP is more common. Yeah, Praveen, can you go on the? Yeah. So in this picture, you can see the pelvic is rolling backward, and because of that, the changes are happening in the spine, like almost the C-shaped curvature you will get, and in the thighs, like the pelvis and hip angulation is increasing, knee angulation is also increasing, and the changes are also happening in the ankle. So this is more common in CP and persons with spinal cord injury, because if I take the example of spinal cord injury, the muscle tone is very low. So because of that, the pelvis is rolling backward, and to accommodate the fall, they are accommodating this posture. They are try to make them balance. Yes, Praveen, can we go on the next slide? Yeah. So this is the combination of actually rotation and the lateral pelvic tilt. This is in some cases we can see in polio, in spinal cerebral palsy, we can see this. The one side pelvic is lifting up, and followed by the rotation also because of the high muscle tone. This is also common, we can see, and we call it as a windswept deformity, which we have seen in the last presentation. And this windswept deformity is majority we can find out in the children with cerebral palsy. Praveen, can you go on the next slide? And this is the pure example of a lateral tilt. We can see one side of the pelvic is higher and other side is the lower. So all these problems happening in the pelvic level, they are affecting the person's spine also. You can see the scoliosis here, the C-shaped curve, like convexity in the lateral side is increasing. The scoliosis is happening in the spine. So this is very common in the lateral trait, and it is common, like we can see in polio, CP, and other disabilities also. Yeah. Can you go on the next? So now we will talk about the child normal posture, like I asked for the neutral posture. So both were the right, but in case of children, because till the age of 5 years, the child is not getting the natural curvature. So we will get almost a flat back with no lumbar or thoracic curvature. We will get the almost a flat back. You can see in the side lying image where the pelvis is marked as a triangle and followed by the spine, and the ear and hips are in the line, you can see, and shoulders for the little, we will get the forwarded or the rolled inward. The child will show this, and the legs get little rolled outward and apart to maintain the balance in the sitting posture. We can see this when the child is sitting, but until the 5 year, we don't need to put any extra pressure to create the postures, because it will again create their anatomical changes in the body, and further pressures will hamper the growth of child. So we don't need to put any extra pressure, only with a gentle support we can provide to sit upright. Yes, Praveen, can you go on the next? So if the posture is correct, and we, or even in the children or the adult with the disability who are having the poor posture, if we give the proper posture, the weight will be equally distributed. If you see the first picture from the back side, you can see that there is a high pressure on the ischial tuberosity, and like seat bones, you can see the which is marked with the red, there is a high pressure, but with the proper support, the weight is distributing. And similarly in the side line, we can see the mark is red at the pelvic, but when we provide the proper support, the weight is distributing through the thighs also. In the both the pictures we have provided, like the person is getting the good support, with that the weight is equally distributed. But if we are, and it is very common, we can see when we are sitting for the longer time on the seat. So you might have seen there is a with the extra fold, that pressure is coming on your seats also, we can see, and with the proper support, the weight is equally distributing. Yeah, Praveen, can you go on the next slide? Yeah, now we will talk about the postural control, which is very important. A stable base is essential, as it will impact postural control and performance. So like in the first picture, you can see the base is very large, followed like this triangle is showing. If you provide a large base, so the person can sit properly without losing the balance. So base is very important, a large base, especially in case of children with cerebral palsy, we have to provide them large base. In the second picture, the base is very minimal. The children is sitting in the cross leg position, like the legs are crossing to each leg, both the legs, and because of that, the person behind who is standing, he is supporting the child at the level of shoulder, but his base of sitting is very less. Due to that, he is having the tendency to fall in the side, and to prevent that, like the child is using the hand. So, and in the third, you can see in the third slide, the very lesser base of support. So to prevent this, the child is using the hands, and this is because of this base of support, less base of support, the child is starting developing the poor posture. So we have to provide them a proper base of support so that he can sit and he can try to maintain. So this posture control, this is called. Can go on the next slide. So this is very new thing which is coming right now in our subject. So the live box. So the live box is basically, if you place your thumb on the ASIS and the upper index finger to the lower rib, so that the rectangular shape is forming, where you can see this rectangle shape is forming. So if it is coming, then it means the child or the adult is having the good posture. But if it is reducing or it is making a triangle, it means the child or the person is having problem with the posture. Praveen, can you go on the next slide? Yeah. So if you see the 10-year child, he is having a good rectangular shape. So it means, that means that his posture is started deviating, but he is able to maintain the posture in almost to the neutral posture. But due to gradual poor posture, the triangle getting a start developing, and you can see in the spine is almost curved to one side, and the pelvic is also lifted. So this triangle is getting developing. So similarly with the age, the triangle is also getting the narrowed, and till in the 16 year you can see it is almost the base of support is very less, and child's spine is almost the bend, and it is touching to the pelvic. So this life box is getting day by day less, and because of that, the person will have the issues with the digestion, breathing, and all these could lead the death after a long time. Yes, Praveen, can you go? So now we will see about the ideal standing posture. So in the standing posture, basically the foots are together and facing forward in the same line, and toes slightly apart. We can see, or the knees together and straight. Young children slightly bent because they do not have a complete extension, and hips are extended, abducted, and rotated slightly. Pelvic, we can see neutral, balanced over the femoral head, and the spine is stretched to maximum length following the spinal curvature in the adult. But in children, the spinal curvature will not be there completely, and head thrust upward, ears leveled, and eyes look straight forward. Shoulders relax one side on the body, rotated inward, and arms rotated internally and palm facing inward. This is basically our ideal standing posture. But what is happening in the abnormal standing, or with if the person is having the standing problem, we will see in coming slide. Praveen, can you go on the next slide? Yeah. So this is yes, this is the development of standing. We all know, like, we are working with the children, and even we have seen in our families also, like that it starts with the rolling and followed by sitting, crawling, pull to stand, cruising, supported walking, and standing and walking. But before going on the standing, can I know, like, at what age the standing developed fully in the children? Like, your answers will be much appreciated if you can put in the chat box.
So your question is, at what age the child can stand? That's what the question.
At what age the standing developed fully?
Develops, okay.
So we have some replies, like this. Anju says 12 to 18 months, and Sarah from Odisha says 8 months.
Okay, any other answers?
Is another answer? Yes, sir. Mostly says 8 to 10 months, sometimes 10 to 12 months.
Okay.
Anyone?
Okay, so we'll move forward. So majority it develops from the 8 to 12, like 8 to 10 months. In some cases, if the child is having some delayed, so sometimes it is 12 months. But it is if it is not developed till the age of 12th month, so that means the child is having some developmental issue, and we should seek the consultation with the physiotherapist, OTs, or the pediatrician, so that we can just identify the issue and we can start interventions to the child, for the child to accommodate to achieve the standing. Yeah, but it is majority 10 to 12 months the child should achieve the standing. Yes, Praveen, can you go on the next slide? Yes. So the like in the image you can see the child is having very minimal curvature, which is start developing with the standing. So firstly the posture control against the gravity child will achieve. So once he is he is able to control his posture, body posture against the gravity, then the secondary curvature starts developing in the spine, followed by the lordotic, then the cervical curvature. Sorry, the cervical curvature developed first, then the lumbar curvature will develop. And when the curvatures are developed properly, the children will be able to sit and stand in without any support. Yeah, Praveen, can you go on the next slide? Yeah. So we are the common standing deviation that we have we may see in the crouch standing with the hip and knee bend, asymmetrical hip and abductor and adduction, and the knees deviations to the side, sometimes inward also, like bow knees we can see. The bow and the knock knee is very common in children and adults also, and the foot equinus and the equinovarus. And the causes are basically the muscular tightness. It starts with the muscular tightness, but if it is untreated or unmanaged, so it may lead the joint fusion also. So that could be the bony involvement will be there in later stages. Yes, Praveen. I think, yeah. With this, I will close my session and I'll hand over to Praveen so that he can talk on the postural support devices. Or if any questions are there, you can put your questions in the Q&A box. Thank you.
Thank you, Siddharth. Thank you, Siddharth and Sudhakar. Hope you can hear me.
Yes, Praveen.
Thank you.
So just Praveen, just give me a second. I will start sharing yours.
Done. Thank you so much, Siddharth. Hope you all following the need of posture care management, and what all the evidences says that posture care is integrated part of rehabilitation. So where we usually divide it into multiple professionals as a posture care management, usually in rehabilitation, start from medical management to the rehabilitation setup, then the home care management, then to the community. So the posture care management is like with the entire rehabilitation approach start from medical management. It could be for children with disabilities or it could be adult with disabilities. So it's an integrated part of rehabilitation approach. So that's all about why this webinar has raised here and why we are discussing such need and evidences related to postural care. So for my topic is very clear. There is a need. You all agreeing and you are all following it. With the particular need, there are clinical evidences say that if such problems happen, what kind of deviations happen in your body. So with that deviations, what kind of visual organs directly, indirectly influence. With that influence, there are a lot of changes happen with the person with disabilities. So to overcome that, exactly what we have to do is we need to bring some solution. The solution is not only for a postural care or posture correction. This is also increase the functional independence and also the decrease the complete need of the physical therapy or occupational therapy or any kind of rehabilitation support. It carries the supportive devices. So that is all about what we're going to see today. So now basically I mean to say you might heard a lot of problems and a lot of issues happens. I'm just going to brief you some solutions in all three postures. Next slide, please. So what are we going to do with this for another 25 to 30 minutes? What we're going to discuss here. So what kind of our posture correction aims? It's bringing pelvis into neutral, lower limbs close to neutral, if possible neutral, making sure that proper alignment for any person in lying. Chest derotation. So what kind of simple solutions can bring him into close to the neutral or maybe the neutral? Head neutral and shoulders are supported. These are the basic parts has to be supported to bringing abnormal to close to the normal or maybe close to the neutral. That's all about our aim. What is all about postural correction. So next slide, please. Next slide. Yeah. So everybody knows the Newton's law. So we just discuss whenever in our rehabilitation, whenever we are applying any assistive device or any supportive device or any corrective device, it starts from any orthotics, a prosthetics, or a simple solution. These three things we will keep in mind. Whenever the Newton's law is applied to any body portion, either in sitting or either sitting in movement. So we need to look whenever the force is happening, there is an opposite reaction happens to the body. So we all agree that the pelvis is the core for our body. Coming to the upper body structure, when pelvis have in sitting or lying or standing any movement, so automatically your entire body follow with that. So the principal idea for us is correcting pelvis first, then going forward to the lower limbs or maybe the upper limbs. That's how this Newton's law follows. I don't want to take much time here. Next slide, please. So just directly move to the lying supports. This is the material used for usually lying supports. Previous slide, please. Yeah. So this all exactly we call it as a full scale of lying system or lying support, readily available even in our country, readily available with many manufacturers or sellers or vendors are selling this. These are basic lying supports which can help to bring it into neutral posture or maybe adopt it or accommodate or correct the abnormal posture into the neutral posture. Nothing but just a padded brackets, the wedges, a foam, a small rolls, some cushions, even bean bag, a non-slippery mesh. There are many devices which can support to bring it into neutral lying posture. Even sometimes there are informal domestic alternatives. We as having in this sector, we always encourage what homemade are in the home available for you to correct this lying postures, because end of the day when we're working in community, a lot of materials which can be available in home, which we can modify into a accommodative device, adaptive device, or maybe a supportive devices to bring it into normal posture. That's the beauty, to bring it a home care materials into a simple solution for lying supports. Next slide, please. These are the basic examples are showing it. Maybe pictures you say that no, these are all very expensive or something. No, these are the simple materials which has been coated or covered with the locally available materials in your local foam shops, or maybe some leather shops where the sofa fabricating shops. There are a lot of different materials. The only request to all of you in this participant group, you have to go and explore what kind of material will help for your user. That's all about the solution. Next slide, please. So this is all the simple stuff works where we have proper holding fabrics are available in the market. Next slide, please. So this is supine lying supports. This is a simple example. The left side, commonly we see this all the majorly children with cerebral palsy or children with multiple disabilities lie in this kind of postures. So bringing into a simple solution, start from pelvis, then lower limbs, then the trunk, then the head, so the child able to sleep comfortably with the neutral posture. Next slide, please. So these are the side lying simple supports, as we are saying. It could be a bean bag, it could be a small pillow, or maybe wedge, or a simple strapping system, or the pillow structures can help him. And always the picture 1 and the picture 2 says that whenever you are giving any such kind of lying support, please put it with any sort of a bed sheet, or maybe some sort of soft towel or something, because they should not move their place where you have assessed and described. The only simple solution, we need to cover with the a blanket or bed sheet so that it will stay in the same.
Some technical error. I think Praveen will join again. Siddharth, can you hear the audio?
I can hear your audio only.
Okay. Okay, let me just continue till Praveen comes. Yeah. Sudhakar here again. So the various supports, what we are talking about, the basic three different lying, right? Like a supine lying, prone lying, and side lying. In all the lyings, if the supports are not provided, as Siddharth was showing, the rib cage can go deformed. The foot can deviate, and then that may lead to the various body positions, right? So that's how this particular supports are given at the various body parts. So when lying supports, always like in our experiences, we have seen many therapists or many different professionals, they give some supports under the legs, between the legs and all those things, right? But it is not only between the legs or under the thighs, it's from the top to down. All the body parts should be supported. The pelvis should be neutral, and the legs should be supported with the different angles, and the arms are supported well, so that they can be comfortably lying down without any like pain, or with the less pain or less things, because over a course it will just improve. Maybe immediately it will not help, but over a course of time slowly it helps. So the support what you are seeing is for the prone lying support, just to keep the hip little bent and knee little bent, and then keep in the symmetrical position on both the sides. That's how I can say. And every support should be placed under the bed cover, and there are materials, if you are keeping above, that should be like in a slippery, non-slippery mesh. That is like what Praveen was saying, the simple stuff work and all those things. Now that kind of materials we can just use it. Next slide, Praveen. Sorry, next slide, Siddharth.
Yeah.
Till Praveen comes, I'll continue. Maybe once he comes, he can take it. And these are the domestic alternate, which many of you would have seen, or many of you would have been using in your practice. But however, these all things, if you see just above the bed cover or above, it can easily move because of the tone, because of the movement. With the one kick, the children will just kick away. So these are the different alternates should be placed under the bed cover, and each support should be measured and supported well and prescribed for the child and in the different positions. So Praveen is here. Maybe I'll hand over to him.
Thank you so much, Sudhakar. Yes, sir. Thank you so much, Sudhakar. Hope you can hear me.
Yes.
Yes, clearly.
Yeah, yes, some small technical error. Really apologize for that, and thank you so much for taking care, Sudhakar. And coming to the next slide, please. Yeah. So coming to the sitting supportive devices, there are, we need to focus from the lying, then going forward from the sitting. As I mentioned, we need to carefully look at with the pelvis. The pelvis is the base. Next slide. So coming to here. Next slide. Sorry, previous slide to that. Yeah. Yes. So coming to the first scenario in the sitting, usually what we see with the adults or maybe with the children with disabilities is flexible posterior tilt. The pelvis is tilted, as that clearly explained. If the pelvis is tilted backward, what happens with the pelvis? So usually if the pelvis is tilting backward, what kind of deviation happens with the spine and with your lower limbs and with your hand and trunk? So how exactly we will be correcting in the seating so that it applies to the spine and the lower limb in neutral posture. So if you can see the pre-seat bone shelf, that is the cushion name, what we call is an exclusive session again for the how to fabricate this, what kind of material can be used to prepare this pre-seat bone shelf, and also adding some sort of rear pelvic pads. As we understand the Newton's law, when you are just giving that, so automatically the body goes back. So to control that, so we need to have a small rear pelvic pad, which we can see here, so that it acts, the support. The support comes and it acts like a neutral posture for the back as well. So bringing to this particular picture to here, just a simple cushion support with the seat and back can make a person to make a person sitting in neutral posture. So that's all about giving a simple solution in this particular scenario. Next slide, please. So there's again adding to this. If you have always, the strapping is the final solution, but if you can able to give you the 2-point pelvic strap, it can able to hold, not to allow the person moving forward. So the 2-point strap can help to prevent the sliding off from the cushion, and also helpful for a wheelchair user with a strong uncontrolled movement, especially when we see with the children with disabilities, such kind of uncontrolled movement. The 2-point strap can help you and hold the proper neutral posture. Next slide, please. The scenario 2, there is a fixed posture pelvic tilt. As you all said, that is fixed. So there is nothing to bring it into neutral, as we are accommodating into what kind of fixation happen. So the back open seat and backrest angle, which the cushion model is showing in the picture here. So that will accommodate whatever the tilt happened. The pelvic tilt has been held to the person with disability or maybe children with disability. So it will accommodate and give a proper support and self-confidence, so that he'll be able to stable in that particular seating position. It could be in the wheelchair, or it could be in the common any other chair. Sometimes we give a lot of special chairs as well for children with cerebral palsy. So make sure that that sort of a simple solution in the backrest, if you are accommodating, so that automatically he'll be able to stable with the whatever posterior tilt happens. So wherever the movement has been stopped or fixed. Next slide, please. Then again, the scenario, the flexible anterior pelvic tilt. So we have seen both the scenarios. Here is the pelvic is anteriorly tilting forward. So when anteriorly tilting forward, to prevent that, what we need to do is wedge cushion for anterior tilt. So that what happens, it will not allow the pelvis to roll again forward. So that's the simple wedge in the seat. It will prevent the flexible anterior pelvic tilt. Next slide, please. Then if the simple cushion, and we need to have a 4-point pelvic, which can also, I just wanted to show some sample, maybe hopefully you can able to see, or if you can see. Sudhakar, please suggest me. I want me to blur my screen.
Just unblur the screen, it is not that visible.
Right.
Also, just make it a little far, little back.
Okay.
Too close, yeah.
Can you able to see me? I guess.
Yes.
Right. So these are the 4-point strap, which it can hold the pelvis in 4 different directions from both the sides, so that if you are just placing it, hope you'll be able to see me. And you're just placing the 4 directions. The pelvic can be supported in sitting position. So that's the name itself says the 4-point strap. So it will not allow the pelvis is rolling. As we said, it is a flexible, right? The flexible anterior tilt. There is a tendency to move forward always, the pelvis. So in the sitting position, first add the cushion, control the tilt. Still, if you feel that in the cushion, the person is moving forward, so always add an anterior, a 4-point strap. It can hold the pelvis into the neutral posture. Next slide, please. So then again, the fixed lateral tilt. So fixed lateral tilt we have built up under the pelvis, the cushion, so that what happens, wherever the fixation happen, it will be accommodating that pelvis lateral tilt. And also the hip side pads in the picture, hip side pads, the pelvic side pads we say, that also can help not to go beyond that. So that kind of a simple build up under the pelvis, so can able to accommodate the fixation, whatever happened in the lateral tilt. Next slide, please. So again, the flexible lateral tilt is a simple solution. Add the appropriate hip side pads and the trunk pad. So the simple trunk pad solutions which we have, it can be fabricated in even your own setups. So this simple pelvic pads can able to help to prevent. And also the hip side pads, what we have kept here, a simple hip side pads. Such kind of side pads can also help not pelvis moving in the side. So these are the simple solutions. Adding in a sitting solution can solve your flexible lateral tilt. Next slide, please. So again, the flexible rotation, leveraging pelvis strap to one side. So this is again the biggest solution is we need to prepare entirely the cushion modification along with a strapping solution, so that it can able to hold, not to move beyond that. So that is the strapping mechanism. This again, strappings case by case, a lot of experience with us also, case by case, we need to understand, and you need to understand your seating solution, where you have a flexibility to fix these seating solutions. So Based on that, if you can able to try many times, which is working close to the neutral, and also you can also add some sort of adductor block. So that is also adductor block also can help not to roll, or maybe a simple padding, or maybe simple elevation in your even cushion also can also help to not to roll with the deviation side. Next slide, please. So these kind of things are fixed rotation. So again, if it is a completely fixed, there is no other alternative solution, but we need to address the fixation. What happened based on the fixation, you need to add some sort of solutions. It could be a hip side pads and opposite, some sort of strapping, adductor block to adapt that particular rotation, not to go beyond. So with this adaptation, or maybe with this accommodation, a person will be able to sit comfortably with that because it's already fixed. So they get able to perform. It could be any kind of activity which he is performing in his seating device. Next slide, please. So the relationship of pelvis, trunk and neck deviations, as Siddharth also clearly mentioned. So whenever any deviation happening with your pelvis, automatically your spine and your lower limbs and your trunk will fall. So please make sure that in your assessments and in your solutions, make sure that the pelvis has been addressed properly and given proper solutions, then work for trunk and then work for the lower limbs. Until you are not corrected pelvis, if you are adding many solutions into the trunk and lower limbs, it won't help. It really won't help. When you feel like tired, what is exactly happening? Whatever I am adding, it's not working because your pelvis has not been corrected. So which we have discussed the scenarios. It could be flexible to neutral, it could be fixed, or anterior tails, or posterior tails, whichever. So you need to address that. First, give the proper solutions for that. Next, go for the alternative solutions of trunk and lower limbs. Next slide, please. So again, hip and knee deviation, as I said. So we can just, whenever the pelvis movement is happening in the picture, you can just see how the lower limbs were, going beyond to the neutral. So these are all the adjustments. When you're not correcting, try to bring your lower limb into neutral. Try to bring it your, the leg into the pushing into the neutral posture. It won't help. So first, try to address what is happening with the pelvis. To correct the pelvis, then automatically whatever the movements is happening with the lower limbs, then the trunk you need to put it. Next slide, please. So now these are the things for the correction of lying and the sitting. Then coming to the standing positions, standing supports. Next slide, please. These are three standing supports. Everybody were aware about it, which we follow regularly. It's supine and prone and upright lying supportive devices, which is highly available in market. Next slide, please. So the supine standard, this is again, the rehab professional has to choose what is exactly supine standard, which condition it will choose. So there's the clearly examples here, the case by case, you have to decide what kind of standing support are required for that particular child or adult. So usually what supine standard says that, so if it is a low tone falling forward, you need this particular device. And also the children with the poor anti-gravity strength. So when you are doing the regular therapy, you'll understand that what is exactly happening with him. The knee flexion contractures, depending on the angle of the tilts, the amount of weight bearing can be reduced. So these are a lot of adjustment options within the standing frame available, and also the lap board is available with you. So even the standing support, whatever the requirement and what kind of the base of support, everything will be adjustable in a same device, so that case by case you'll be able to use for the children or adult with the disabilities. Next slide, please. Next slide. Yeah, this is a prone standard. This is again head control and who have this particular issues, tight hip flexors, extension strength, and the inhibit the extensor tone. These are all the particular reasons. If the child is falling or adult is falling, we will choose this particular prone standard. In this also again the standing positions from completely to the lying to slowly there will be an adjustments to bring it into complete weight bearing position. So you need to decide what kind of position he require from initial to the end position. So the end goal achievements. There are a lot of safety. There are a lot of the safety protocols has to be followed. There are a lot of straps is available. So which kind of strap, when to use, where to use, the case by case it affects. So always, the prone standard, we need to be a little more aware the user is capable enough, and better initial days, the therapist can assist him very closely so that we can prevent a lot of issues further. Next slide, please. Then upright stander, this is the two standing, already you are achieving by case, then improvement is going forward. So we have a final option, upright stander. Some users, we have much improvement, but they have a minimal support required. They'll be able to manage their standing posture. You can choose the upright stander. The upright stander, the many models are available with this, but there are many safety protocols as been given into this picture. As I said, if the child is having a good neck control, a good upper limb control, you need a minimal support with the knee and hip, and sometimes with the ankle. So such kind of children or adult, you'll be able to choose this standing support. And maybe with experience, what we would like to add here is you can also choose a close to the back wall or maybe close to the safe environment, so that further injuries can be prevented. This kind of device, please try to observe where the supports has been provided. Maybe the manufacturer give you n number of additional supports in same standing frame. Each child to child or adult to adult, what kind of standing supports he require. If he require a measure into that, try to add into it. If it is not required, measure that. So please assess and try to reduce as much supported devices based on his abilities, based on his capacity of standing. And again, as some children may fatigue easily when you are choosing in the standing frame, using appropriately even with orthotics. So make sure that the child fatigue has been taken care and giving proper rest, and also explaining to the caregiver what is exactly happening with the standing frame, what kind of improvements happens with the standing frame, so that everybody were available. Next slide, please. So the local solutions, again, as I said, there are many available devices are there, but even in the home, as we all said that as per CBR, as per home care management, there are some materials are available. Whenever you're using this such kind of home care materials, make sure that the safety is first important. The safety, why I'm saying again and again, it should not make any damage to the person's abilities. So it could be adding soft foam, giving with the straps, not with the pokey, or maybe with any hindering issues with the device. Make sure that before testing or before using it, all the things were under control and safe. Next slide, please. So the basic, which is a simple wooden frame or simple wooden structure, will be able to bring it into some sort of prone, standing frame. Giving the adjustment, as I said, depends upon the child ability, will improve or will bring it into the normal standing posture. Next slide, please. Simple solutions. Many of you are already following in your community setups, the simple 2 sticks with the proper strapping, or maybe we can use some sort of, usually people use this in our experiences with the tire, or maybe with some sort of strapping in available material, something like that. And with the parallel bar adjustment as a standing frame. So can you see sometimes with the adjustable parallel bar along with some sort of sticks, so that they'll be able to take some rest and again walk, again take some rest. So it depends upon whatever the child abilities and the material availability. We have to guide a home care person or maybe a caregiver, what kind of solutions can help in the home. Next slide, please. Simple as a used bucket or maybe wood bucket, or sometimes many people use this with the trunk of the tree sometime. So giving them some sort of activities with them, that is also very important, because it's not just simply standing with them. A lot of special educators, a lot of speech therapists will achieve some sort of their rehabilitation goals using such kind of frames. One way standing is also happening, another way the therapy is also happening. There are multiple ways to achieve appropriate posture, but child will not feel that, or the child will not away from that particular device. Just saying, some parents will put some sort of diagrams into it, some sort of puts their favorites colors into the devices, so that the child will attract and use such kind of devices, and other rehab professionals can use their therapy goal as well. So that is all about functional usage of a sitting or lying or standing devices in your rehabilitation. How effectively you'll be able to achieve both the goals in the same time, sometime, and also the separate way. So if siblings would like to involve in the child, so always involve the siblings during the postural corrections, so that they'll not concentrate what has been fitted, what kind of additional solutions has been added into their body. They'll forget all about it. They just try to enjoy and play with the siblings or externals. Next slide, please. So any solutions, any device, as I was talking about last, more than half an hour, I'm explaining you all, the safety is very, very important. and the final solution always with the multiple tries. Once you feel that the final solution is absolutely working for a child or adult, so you need to focus slow repetition way as we follow in our rehabilitation. So any our goal or any our interventions will not go in a vigorous, so we'll go with the slow. So it could be a duration or it could be position and the place, whatever, slowly improve. And there should not be a no sharp edges. Doning dofing should be very careful. We need to have a quick doning and dofing, understand the child abilities, the fatigue, respect to them as per that, and create that environment as friendly and the play environment so that the child or adult would like to participate and have that appropriate solutions. So these are all the things. And also if any skin is getting redness, the sleeping is getting any disturbance, the cooperation, all those stuff, any solution when we are giving, we need to recheck with the child sometime and also with the parents and caregiver, because it's not just a simple solution can bring a quick change. No, it is a slow process, but we need to correct as much we can do it. And as the slide is talking all about, get familiar with the solution. Equipment is not the end goal. So we always say that appropriate a multidisciplinary or transdisciplinary rehabilitation approach followed by a posture care management integrating into your rehabilitation approach will make a huge difference in rehabilitation. The child and adult can get a huge rehabilitation goal to be achieved in a shorter span. So what happens with the regular practice, the shift of rehabilitations or postural solutions to sitting, lying and standing to multiple professionals, somewhere it will be changes. So what our request is, as a rehabilitation person, try to incorporate this into institution-based also and the community-based, and train the parents and caregivers on importance of posture care management so that the solutions were inbuilt from institution-based to home care-based rehabilitation. So posture care management is a part of rehabilitation and it will give a good results or excellent results along with our rehabilitation approach. Next slide. Next slide. These are some sort of references which we will be able to share. A lot of references. Please go through the references and you'll get a lot of inputs from that. The sessions were, as Sudhakar mentioned, Siddharth mentioned, it's just a simple idea what is the importance of this, but this references shows you what is happening across the globe.
So, excuse me, sir. Sir, we have one question.
Yeah.
A female obese 70 kg plus CP adolescents. The child is taking nutrition consciously, avoid junk food. How to make her lose weight?
Okay. It's an interesting related question. So it's again child to child what I wanted to give you the answer, but so what we can do it, we need to consult, what is exactly the physical performance of physical exercises was happening, and in related to the posture, how the corrections were happening, and maybe some sort of consultation with the dietitian so that it will be able to helpful for them. As a combination is a proper physical exercises and the good posture, the consulting with the proper diet and other diagnostic procedures will help the case by case how we can able to reduce the weight.
Thank you so much, sir. We have another question. Do you provide services in Trivandrum?
Yes, we do provide. Motivation is always believes the partner-based approach. So what we do is we associate with the local partners so that they'll be able to give the grassroots services and equipping our partners. In Trivandrum, we do have a couple of partners. If they can reach to us through the mail, we'll be able to support them.
Okay, thank you so much, sir. Means a lot.
Can I add on the question for the first one, that obese things? Sudhakar here. I don't know who asked that question. The direct answer is definitely not there. What we could suggest is first do the proper assessment. What kind of the posture the child is adopting, the adolescent you're talking about, right? So just I suggest do a proper assessment in lying. What is the pelvis? How the legs and knees are there, and then how in sitting position, what all the pelvis deviations are there, spine deviations are there, what Siddharth and Praveen was talking, the different angles, right? The trunk, the hip and the knee angle, the pelvis and hip angle. So these angles you can try it out and then give a good comfortable position in sitting as well as in lying position and give some encouraging them for some physical activities and all those things. And we need to see the weight reduction protocol. We cannot suggest. We need to really find out why the weight is increasing for the child. All those medical checkups can be done. Then based on that, you can do the other activities that helps. That's what maybe as suggestions we can tell. But still, we need to do a detailed assessment for the child. Then only we can advise some of the postural related managements for the child or the adolescent. That's the thing I want to give you. I think one more question also we are having, right?
Yes, sir. Yes, sir.
Yes.
One question is, do you provide wheelchair servicing?
Yes, we do. They mean to say the wheelchair service providing, or put them into say repair and maintenance or something.
Okay, thank you so much, sir. Sir, one more question. What is the difference between upright standards and prone line standards?
Okay. So I think I was just reading the question. So see the difference, it depends upon again the child ability. If it is in an upright standing position, it will give who have appropriate head control, appropriate trunk control. So they'll be able to have minimum support requirement, so they can able to use the upright stander. If it is in a prone, so they have a little bit the head control, but they need some sort of additional supports in the trunk and in the lower limb. So they'll be able to go to the prone lying. So how the standards happens based on the improvement, start from the supine, achieving some sort of things, then with the prone, then with the supine standard. So it depends upon the child abilities. So we need to choose what kind of appropriate standing posture can choose. It could be a supine, it could be a prone, or it could be a upright. So these are the three things we need to assess and decide what kind of standing support can help for that particular child or adult.
So one more question. During the lying position, all the support material needs to keep under the bed sheet during sideline or a supine lying position.
Yes, exactly. Very good question. So any lying posture when we are correcting, so after assessing, after the correction, after the assessing, you are achieving that particular neutral posture. We need to make sure that it should not replace or misplace where you have provided the device. For that reason, with the blanket or maybe a simple towel or bedsheet, even some material we have shown with some sort of cushion cover set of material, where can adapt with the same place. So it will not misplace. So once you achieve the final posture, then you need to place that on top of the whatever the supportive devices we provided in the line.
Sachin, you are on mute.
Sir, Sarah Odisha Rising Foundation want a CP chair for ID school. Can you help?
So you can just write to us, Sarah. You can write to us with our info. Personally, we will also reach to you. So we will help you on that.
Okay, thank you so much, sir.
Any other questions? Sachin, you have a small presentation to be shared right now, right?
Okay, okay, sir.
Please go ahead with that.
Sir, visible?
Yes.
Yes, it's visible, Sachin. Please go ahead.
Good afternoon, everyone. I, Sachin Kumar Konde, a lecturer in occupational therapy from CRC Ahmedabad. Today, I am presenting a topic, a role of ergonomic approaches in a postural care. The importance of employment to people with a disability has been increased recently. Basically, employment, a person with a physical disability for now are interested to do work, feel independent, make independent their lives. So we have seen some restaurants, cafe, and all the high-reaching posts. A person with a disability tried to reach there and work a good and efficiently. A participation in working life as active producer has been the main factor in a community integration of people with a disability. It has been proved that if the people with a disability are given the opportunity to develop and use their work capacity, they can be as successfully as those who do not have any disability. And nowadays, the more rational way of helping people with disability to provide them with a profession and work. Basically, now everyone prefer to go out, make independent their life and work harder. So it is a good way to give them a proper opportunity, proper work. Vocational rehabilitation or a work hardening is a process that helps someone to overcome the barrier when beginning to work, continue to work, and returning to work after any accident, illness, and order. The employee is selected according to his or her ability, according to work to do, to be done. It is very important that a place to be work matches the physical and psychological practices of employment. Basically, if they work, they need all the things, all the assisted device, and all the things. So ergonomics is important at working life as effective productivity. So we have three types of ergonomics. One is physical ergonomics. In physical ergonomics, is the human body respond to physical and psychological workload. For example, repetitive strain injuries from repetition, vibration, force, and posture fall into the category. In cognition, deal with the mental process like a mental strain, workload, decision making, human error, etc. Sorry. And third one is organizational ergonomics. In here, in organizational ergonomics, we organize the things, we decide meetings and all the things that's come in organizational ergonomics. What does it mean in organization? Particular process in the work environment such as shifting work schedules, job satisfaction, motivation. Now, what does it mean? The ergo means work and norms mean natural laws. Ergonomics is the science and the art of fitting the job and the workplace to workers' need. It is the study of work. In ergonomics, we try to study the work environment, work structure. It is the way to make jobs, tasks fit the employer better. It is the way to make worker easier. Principle. But basically, we have some principle. Work in a natural position, reduce excessive force, keep everything in easy reach, work at proper height, reduce excessive motions, minimize static load, minimize pressure points, maintain a comfort environment, make display and control undesirable, move, exercise and stretching, like exercising, stretching are more important. Effect of ergonomics. We have two types of effect classification: communicable traumatic disorder and strain and strain. In communicable traumatic disorder, injury to soft tissue caused by prolonged exposure to multiple ergonomic risk factors, for example, finger, wrist, elbow, and neck. In strain and strain, we have some sudden jerks and sudden injury. Injury to connective tissue caused by single force events, lifting heavy object in upward position, common to large body segment, example, back, legs, shoulders. What to do? How we now we discuss about ergonomics. Now how we can prevent the warm up and stretches before activity, that repetitive stretching. And if we have some like some type of work which take some type of heaviness and all the things, then we need some warm up and stretching, like in easy like हम अगर ऑफिस में भी मॉर्निंग में स्टार्ट कर रहे हैं तो we need some warm up or stretching exercises before starting the work. Take frequent breaks for any substance posture every 20 to 30 minutes. We take some like interval after working 20 to 30 minutes. Respect pain and posture or stop painful occurrence. If you have a pain and something in your body or something negative things, so please take rest or respect that position or respect that pain. Recognize early sign of inflammation process and treat. If you feel something or some disability or some type of pain, so respect that. Be aware of workstation environment. Advantages. The benefits of applying ergonomic principle: maximize productivity, efficiency, and quality. Reduce muscularity disorder risk by eliminating or maximize ergonomic risk factor. Improve employee morality. Cost saving associated with injury-related treatment. It can help you to work safely. It can make more comfortable. It can prevent injuries. Thank you.
Thank you, Sachin, for your presentation. Maybe we have one more final question, Praveen, like where to purchase shaped foam pillow or support?
Yes. So as I mentioned, what ready-madely available based maybe some sort of rehab solutions in your place. I'm not sure that which part of India you are talking. If it is in Bangalore or some other place, there are many resource centers are available with that. And the best answer it could be based on your assessment. Customizing will be more easy option. Keeping some sort of local materials, as I said, that buying some sort of foams in local shop will be able to customize it. I think maybe you can just reach us what type of pillow or if you already assessed and you're not getting, so you can just write to us and we'll be able to support you based on your geography.
We have one hand raised. Let's see what he wanted to say. Chauhan Bharti Jawan Singh, you are allowed to talk. Now you can just unmute yourself and talk. I think she's having some issues with network. So Praveen, you can continue.
So we are finally end of the webinar. Hope you all enjoyed listening. Lot of inputs in the same webinar. Start from evidences and the clinical inputs from Siddharth and the evidences from the Sudhakar, and just a simple solution can create a bigger change in their posture. We have seen in this webinar. This is a continuous process. As we said, it's a long unmet need or maybe unspoken about in the rehabilitation. That's the area where motivation would like to bring our expertises to all of you, and so that you'll be able to bring some changes in your rehabilitation setups. So what closing remarks from our side is, we just wanted to say that try to inbuild this knowledge, try to seek more knowledge from your the needs from the children and the parents and caregivers and the adults, and try to incorporate or integrate this posture care management into your rehabilitation approach, so that the carry forwarding of your rehabilitation, it could be a therapy or special education or maybe speech or whatever, so it will continue into the process of in all the posture, start from sitting, lying, and the stand. So that's the we just wanted to convey through this webinar, and also would like to say huge thanks and appreciation and all the support for CRC Ahmedabad. The way when we decided to associate with them, they given huge support for us. Thank you so much for entire the CRC team, and also would like to thanks to the panelist and our regional director Gitanjali here. So thank you so much for all the support and allowing us to do such kind of webinars where it is an unmet and unspoken in the rehabilitation approach. So thank you, and not but not least, all the participants who have registered and thoroughly following, sitting in your chairs for last 1.5 hours, 2 hours. Thank you so much for patiently listening all the way from across all the states in India, and also we have a participant from Bangladesh. Thank you so much joining with us and supporting and adding your sharings and inputs in your chat, and which make us more active participation and encouraging for us to conduct these sessions and conduct such kind of webinars in future too. So once again, thanks all the team members of Motivation as well who supported and taking care of all our works when we are developing and participating in this webinar. Big thanks to everyone. Thank you so much.
Thank you
So
so much.
see you all in future for more webinars. Please, follow our web pages, follow our website, and follow our social media portal for more updates and such kind of training and service related activities. So look forward to see you in other platforms. Once again, thank you so much.
Thank you so much, sir, from team CRC.
Thank you so much, Sachin.
Okay.
Bye, everyone. Request Siddharth to stop the recordings and the meeting.